Okay, so last section here, we're going to look at some health promotion. I told you my stuff is real broad. So what I would want you to think about as you're looking through some of this stuff, like I gave you all the, if you're this age, you need to have this, this, and this done. You know, that stuff changes constantly, the recommendations for some of these screenings too. So these aren't absolutes, okay? Right now it's a topic of conversation. We're going to have some of the different screenings, the different types of screenings, but don't sit down and memorize these, okay? It's about understanding them, about knowing when they would be appropriate for the different age groups. I told you my stuff's real broad. So my other broad topic is health promotion. So let's just review what some of these words mean. So I think 111 is the first time you heard this. Wellness, illness, health, wellness, illness with Miss Almond when you talked about the continuum. So health promotion is behaviors of somebody who's motivated to increase their well-being. So what do you think a good example of a health promotion would be? Exercise, diet exercise, very good. They're trying to promote their overall well-being. What about disease prevention? The basic definition of that is a desire to detect disease or to avoid it. Okay, just real basic. So give an example, disease prevention. Sorry, sunscreen. Sunscreen, that's a good one, yeah, because we're preventing skin cancer, right? Now we have to think about across the continuum, because that's what I'm charged with this semester, is talking about health promotion for this population across the lifespan. So don't get hung up on a bunch of stuff. Primary and secondary and tertiary prevention. Those are terms we've also heard before, and areas that NCLEX likes to kind of dwell on. So primary prevention is to promote health and prevent disease. So it's a combination of the two things that we just talked about. That's why we do risk assessments, get regular immunizations, diet, exercise, routine appointments with our doctor to get our physicals or just basic medical exams, right? Versus secondary, that's screening and detection of disease. So this stuff includes the self-exams we're going to look at, mammograms, because after a certain age, that is routine. And the goal with secondary is to identify, reverse, and reduce the risk. And when we look at tertiary, that's all in that search world. You've already got the problem, and now that's the rehab afterward, reversing the effects of it and then the rehab process. So really we're focusing on primary and secondary prevention measures for the rest of this material, because this is health and wellness that continue. So you've got these terms. Don't scroll over real big. Health promotion, the basic definitions in your concept list, so is disease prevention. And primary and secondary is what we're going to look at, okay? All right, so health history and physical exam. Those are kind of recommended across the lifespan at certain intervals of time. You know, when we're 5, we go every year, right? You always go get your physical, you go to school, your kid, when they're a little bitty, they go to the doctor once a year for a checkup. And after that, it kind of moves away from that. But people still should go and have those regular just checkups, just because, for good measure. When they come in, the role of the nurse would be to get information for the female where they can write menstrual history, number of pregnancies, GP, right? The exposure to medications, so what are they taking home? Are they a nurse working on a med-surg area giving methotrexate? What do you think that might cause? Potential for spontaneous abortion. Okay, so it's not just about are they taking them, what are they exposed to? Incidentally, you'll see those medications we talked about earlier are on your hazardous medication list. And if you are a woman of childbearing age and you're thinking about having a baby, be careful. That's why that hazardous medication list exists, because even handling products like methotrexate, your body is absorbing some of that and it could cause a risk to spontaneously abort. So be thinking about that. Somebody says they're a nurse, you want to kind of know what they're into. Or a pharmacy tech. Remember, before I gave drugs to people, I used to sell them to people. So there were certain medications that we females just did not interact with, and it was because of the risk. So understanding that goes a long way. Are they having pain with their menstrual cycle or with sex? So pain with menses is dysmenorrhea, right? What's the primary cause of dysmenorrhea? Secondary dysmenorrhea? And that would also cause pain with sex, right? So understanding that, knowing that as a nurse, in big general terms, now we're going to be wondering, is there potential for this to be a problem? Are they having any vaginal discharge? And if so, odor, color, all that stuff next week that we're going to talk about, it's a good thing those pictures aren't scratches here, because those odors aren't always the best, okay? You know, we never encourage you smelling up. But there are just sometimes you absolutely can't help it, right? Coach your face, it's big time. But none of that's normal, right? And what's their urinary and bowel function? Sexual history, which includes the number of sexual partners and any potential for physical or sexual abuse. You also want to know if they have a history of STDs. If so, was it treated? Next week we're going to talk about what some of them look like later on in life when they aren't treated appropriately initially. Any past surgeries or procedures, especially if we're talking reproductive. Chronic illnesses, any disabilities, and then their family history, because family history can certainly play into some of these problems. So all the basic stuff, right? Now, for a physical exam, unless you have been specially trained, a nurse does not get all up in there. You don't part the waters and go up in there, okay? Our role with a pelvic exam, or even a testicular exam, is more supportive. We're there to assist the provider and to be that chaperone. If you are specially trained and you're going to work in this environment, then you may learn all the tools and tricks of the trade. We're going to talk about them in general, but not exactly how to go all up in there. Remember, from day one, we've always said a good nurse will ask, a great nurse will look. It's that visual inspection that tells you more than anything else, okay? So by no means am I here to teach you to do Now, health screenings and counselings, this is across the lifespan. This starts with the young adult. Your adolescent slides give you some adolescent information, but then this moves on into kind of time frames of life. So this is in your med-surg book. That's exactly where I got it out of. It's on 1616, and it talks about the different age frames. But remember, these change, and depending on what's going on with the female, they may be a little different. But they're kind of broad. So from ages 19 to 39, that female should be getting those annual pelvic exams starting when they're 21 years old. If they're sexually active, they need to get that pelvic exam a little sooner. With that pelvic exam, there's usually a clinical breast exam. So that's different than a self-exam. All females should be taught to do self-exams, and we're going to look at that specifically in a minute. But the difference between self and clinical is the clinical exam is done by a doctor. Again, if you are going to be a nurse working in this area, you will be taught how to do a clinical breast exam. As long as there's two of them and they kind of look the same, that's our role right now, right? They need help with contraceptives. They're in a window of time with your childbearing. So next week, we will talk about all the different options. We're going to put our hands on them. I think just about everyone you can think of across the hall box, so we'll bring them over here. And it's a good time. If you've never seen a cervical cap, it's a great time to see it in here before they're pulling it out of somebody, okay? Or find it in the bathroom on the floor. Just saying. So that will be next week. It's stuff to come. But we need to know what the options are, and they need to be counseled on that. There are more things than just birth control or injections. This group is in that window worry about high-risk sexual behaviors, multiple partners, so making sure that they have education on reducing that risk, and that is part of the STDs that we'll talk about next week as well, and safe sex practice. So this part of it, a lot of this lecture, usually I do one day, one the next, but they're split with this test. If I haven't gone too far right now, we'll get there next week, because that's next week's lecture is safe sex, contraceptives, STDs, okay? So the diagnostic tests are recommended there, and this is based off of the current literature, but it changes all the time. We do need to make sure that they are good with hygiene measures, injury prevention, nutrition, exercise, screening them for abuse. This is a huge window of people who do have that domestic violence at home. Number 212, you talked about domestic violence, and interpartner violence, dating violence. Now we've got the whole human trafficking element to think about as well. So assessment for that, assessing for the use of alcohol, tobacco, drugs, and is that a coping mechanism? And then what are their life stressors, and are they up to date with immunizations? And even immunizations change constantly. So the CDC is always going to be your best resource for immunizations. Next week, I believe, is when I'll turn on a pediatric set of slides about immunizations. Don't even bother to memorize the immunization schedule. That's not what this is about. When we talk about immunizations, it's about the disease itself, what it's there to prevent, and what it would look like, because some people choose not to be immunized, and then what's the risk to our other populations. So that's a couple of days of your life and a big space in your brain you can save, because that also changes constantly. So this is the same information, but it's that middle-aged adult, so that 40 to 64-year-old window of time. It's the same for the most part, except now we're starting to think about menopause. Remember, this is the window of time where that transition can start to occur. So anticipatory guidance, if we're thinking in those terms, and you're working in a doctor's office or a clinic where you're going to see females frequently, thinking about what's to come as they start to talk about changes in their menstrual cycle, being able to guide them through that time frame is important. This is also a time we're starting to think about bone loss, and they'll start to have DEXA scans, starting to determine we'll set that baseline so that later on we have to go to and look for osteoporosis. This is also a good time for the first mammogram. So again, we have that baseline. Usually that first one is done late 30s, early 40s to set the baseline, and then based off of risk factors and current recommendations, they're going to start to have those more consistently. We also want them to get their cholesterol screenings because we understand that's a risk for heart disease, and having, again, that first step and later on comparison to kind of see what's going on is super important. For men, we're going to look at the risk for colorectal cancer. That's on later. And then bone density, TSH testing, hearing and eye exams, because there is starting to be changes in those function as well. Health screenings and counselings for the older ones. So this is that 65 and older. Again, they still need health exams. Your med-surg book has it listed as annually. Current practice on that is not annually unless there's some issues. If they've had pretty regular exams and they're normal, they push them out even to maybe 2 and 3 years. But remember, the big thing here is they shouldn't have that regular vaginal bleeding. And if they start showing vaginal bleeding, that is an absolute indicator there's a problem. Clinical breast exams, again, your textbook still says annual, but that's not most current practice. And they really are in that group that we don't want to think about for high-risk sexual behaviors. So there's an article I'm going to give you next week about sex in the older adult, because they're still doing it. Okay. And make sure that they have that knowledge. Now we're worried about risk for falls, because as we get older, our mobility starts to decline, and if you're an older female, osteoporosis, and you fall, now you got a broken bone on top of everything else. So injury prevention is geared more toward that. And there are your diagnostic testing. So basic, generic, open-ended, constantly changes. Ain't no need to memorize all that either, right? Just understand how they apply. Now, a clinical breast exam is done by a medical provider. It can be a nurse practitioner, somebody specially trained, the doctor. Usually, again, our role is supportive. So that provider will be checking the shape, the consistency, and they feel around. All females should be taught to do self-breast exams. You, as a young female, when you go to a health fair or wherever, you're going to see these pictures everywhere. And there's no right or wrong way to do it. Bottom line, do it. Feel around. Make sure that you know what it should feel like and you don't feel anything abnormal. Because a lot of times, the female at home will be the person to find something that doesn't quite feel right and come in for additional screening. The best time to do the self-exam is that week after your cycle. The week before your cycle, there's a lot of things going on. That hormone shift's happening. They're tender, they're sore. If you're a caffeine drinker, then you might feel more lumps around in there because that does cause some more fiber changes inside the breast tissue itself. But bottom line here is being aware of your own self. Your med search book gives you real detailed step-by-step how to do it. I didn't write down the page number, but I did find a short video, not cute, but just a little short video that we're going to watch of a provider explaining how to do it. There are two most important components. The first one is look, and it gives you 3 different positions. Standing, turning, and then it has you put your arms up and leaning forward. Because the changes of the breast, the way they change, matter as they change position. And then the other one is the actual feeling. A lot of women do this in the shower because the soap provides that lubrication. So we're going to watch this quick video of self-exam. Let's hope it works. Because, you know, the technology today is not a little thing. All right, Dave, I need you. Uh-oh, what'd I do?
Yeah, it's not quite the same as switching. Share screen.
Just stand still. Just stay with me. Here's the card.
Breasts, to see if there are any differences in every woman understand the basics. To see if there's any difference between the two. Hi, I'm Dr. Lark. What are the breast surgeons at City of Hope? Today I'm going to. Hi, I'm Dr. Lark. What are the breast surgeons at City of Hope? Today I'm going to talk to you about self-breast examination. Around 8 out of 10 women detect breast cancers or breast bumps themselves. Therefore, it's important that every woman understand the basics of self-breast examination. There are actually 2 components, look and feel. For the first part of the exam, looking, you want to stand or sit in front of the mirror. With your clothes off, you want to look at both breasts to see if there are any differences between the 2. Examine the nipples to see if there's any difference between the 2. One rather than the other. This one holding hand. And you want to put your hands on your hips. Turn from side to side to see if there are any changes. While standing, you actually want to put your arms forward on your hips. And this will bring out lumps that might not appear otherwise. It's important to raise both arms above the head. This will draw out any puckering or dimpling for masses that might be underneath the nipple. If you're standing like this, and you have a mass that's kind of in the lower part, you might not see it at all. When you raise your arms, what happens is that mass kind of stays, and then the skin kind of pulls it as you're pulling up. That was the first part of the examination. For the second part, you want to be lying down. You want to put your head on a pillow to prop yourself up and place one arm behind your head. Then with your other hand, you want to use your first 3 fingers. When you use only 1 finger or 2 fingers, you can actually separate the breast tissue and think that you feel something that isn't there. You can do this one of 2 ways. You can either go in a circular motion all the way around the breast, making sure that you overlap every area, or you can go up, down, all the way across. I prefer the circular motion, from the collarbone to the sternum, the mid-chest, below the breast, and then all the way actually out into the underarm. Lymph nodes are underneath the underarm, and sometimes those can become bigger. When you're doing the breast examination, you're looking for things that feel different from the surrounding tissue. What you're looking for is something that stands out, something that feels like a pea or a marble or a walnut. You want to make sure that you do this examination same time each month. Remember, the most important thing about a breast self-examination is to know your breast. That way you can note any changes in what you're doing.
Stop sharing. You share. Share.
And we love you.
Yeah. There you go.
So
Stop there. Stop sharing.
your 2 books give you just a little variance. The bottom line is look, feel. to yours.
And
And usually, I don't know what to do. Stop it. I'm just gonna break it. I can't. I just can't. So, like she said, lymph nodes, so it's really important that you're examining up into here. And then if you are doing it in the shower instead of laying back, when you're just feeling for lumps. But realize the best time to do it is that 1 week after. And like she said, do it at the same time every single month. Thank you, Dave. I love you. I don't know what you like, but tell me and I'll get you some cookies or something. I just couldn't today. There's just not enough for me in there.
I understand.
Do it today.
I was just kind of rattled with myself still.
So one of the matching things I gave for those on the terms to know was a matching about the steps. So it came straight out of my circle, okay, which has got the most illustrated information. You will learn about breast cancer as a senior, but we are about the prevention right now, about health promotion, disease prevention. And so self-exams should be taught. Females should be doing them monthly. And they usually the first time to pick up on a problem. There's some school of thought that not everybody should do this. This power of suggestion goes a long way. If they feel something, then they're in there all the time. And sometimes there's unwanted diagnostic tests that are done. That's kind of a personal thing. I feel like if you are taught to do them correctly, there are a lot of people who found problems at home and been able to catch it a lot sooner. Don't expect a softball. Hey, you find a softball, that's way better. Like she said, about a pea, something that feels small. And usually, as you move across it, it's not moving like the other tissue does. So those are the things that you want to teach this person, okay? And then it would be followed up with a clinical exam, and then even more diagnostic testing from there, okay? So when you get to the chapter about the breast screening and stuff, realize it talks about breast cancer. It talks about all the changes that can go on in the breast. That's later on. So just the section that I gave you, which is on the screening part of it. So exams, okay? Pap smear. I mean, we can talk about screening without talking about this, Jewel, right? So again, the time frame varies based off of previous experience and that sort of thing. But the rule of thumb on a pap smear is a female should have one once they've started to become sexually active. And if they're not sexually active about the age of 21, they should have had their first exam. Based off of the outcome of that and kind of the time frame they are in life is going to depend on how more frequently they follow up and have those done. Once you get out of that window of having children, they extend it out a little bit more. It still needs to be done across the continuum. So just like the picture shows, the best position is lithotomy. On your back, feet in stirrups, right? Jeff's never been there, but girls would all have pleasure, right? Again, the nurse's role is supportive. So your role as the nurse is going to be to explain to the patient. They're going to feel some cold sensation and maybe some mild discomfort. It shouldn't hurt. You are the chaperone for the provider, because this is always a two-people game. We don't do this by ourselves. I'm getting your equipment ready, so the equipment that's needed for a procedure like this, other than the gown for the female, would be drape, the actual speculum itself, and I have one across the hall. If anybody wants to look at one or play with one, we need lubrication. And then the supplies to gather the sample, and that depends on where you are. From there, position her in the lithotomy, get her feet up in the stirrups. If you don't happen to work in a place that has stirrups, that's okay. Bedpans are multifunctional. You turn a bedpan upside down and now it becomes a makeshift way to be able to do a pelvic exam, because it does shift that pelvis a little bit. So that goes up underneath her, turned upside down, with the lower part down, your fire hat part. The stand-in part, that would be underneath her. From there, the female needs to put her legs kind of beside each other and then flare them open like a duck. A lot of girls want to put their legs way far apart. That actually narrows down that opening. So their feet just kind of go hips width apart, but then they flare their knees outward. So again, that's nursing. We have to get them ready to go. And the provider will insert the speculum closed, turn it and open it. It's cold. There's some popping sounds. And for someone who's never had one of these, the nurse's role is the education and support. Usually you stand there holding hands. Nobody likes this out here. Every time somebody does. The provider will take the sampling from the inside. The eyes, when you go inside, it should look like that. It should be nice and round if they've never had a baby. If they've had a baby, the eyes will have it will be split. It will be obvious that they've had a problem. Or we may see genital warts in that area, discharge, inflammatory responses going on. So there are lots of things that can be visualized. The provider, as they're inserting it and removing that speculum, they are looking all the way in. They're looking at the os itself, but also the lining on the inside. And then there's swabs used to get your specimen. And then some places, some offices run them right there on the slide. That might be your job as the nurse. That would be training you to receive later on. Support, set it up. We really need us to do it unless you're trained. Okay. Have your assigned nurse like Ms. Untitled. She does pelvic exams quite frequently. But that is an additional training. So I don't want you to feel like you have to go out and learn to do a pelvic exam. This is not something you can go home and do. Right? Go listen to heart. Get that. All right, mammography. Mammography is basically an X-ray of breast tissue. That is done as routine screening, and then also helps us to determine breast cancer in women. So usually there is a mammogram done on a female in her late 30s. Set that baseline, and then it will be used for comparison later. The newer mammograms are 3D imaging. Doesn't mean it hurts any less. You know, you put your boob between two glass doors and close them, it don't really feel very good, right? So discomfort is common. Outright pain is not common. And then the female will get a report back on the tissue. The newer exams are offering a lot better pictures, but the problem is they're also offering a lot of concern because people are being called back more frequently because they're more detailed. A woman who has very small breast tissue will get a high density report, meaning the tissue is real packed in on itself and it can't be seen very well and visualized. They may have to follow up with an ultrasound. So again, this is a time that you may see a female who's having fears thinking she has breast cancer, but it's really because the tissue can't be seen very well using a traditional mammogram. So the follow-up on that would be the ultrasound. And then beyond that, if there's some concern, they would do more diagnostic testing, biopsies, and things that you're going to talk about later on when we talk about breast cancer. So routine mammograms are ordered, and they should be done on all females, especially as they move with that menopausal time frame. Considering modifiable and non-modifiable risk factors for breast cancer are important right now. So what's non-modifiable? What's it mean? You can't change it. You can't help how you were born. You can't help your family history. None of that stuff. So risk factors for breast cancer are the same pretty much for any other disease in life. Your gender, your age, and kind of what you were born with, right? Your race, your personal family history of breast cancer, things you can't change. When you started having your first menstrual cycle. Modifiable risk factors for breast cancer. We're doing health promotion, right? We want to be teaching that these are modifiable. A woman who's not had children or not had children by the age of 30 is at higher risk for breast cancer. So if this person is of childbearing age and they keep saying, well, I'm going to wait later on until I get my career established. Education goes a long way. So maybe do it sooner rather than later. Postmenopausal use of estrogen and progesterone has been shown to cause breast cancer. Can you choose to take hormone replacement? You can make that choice. So remember that could be considered modifiable. There are other options, and having a discussion with the provider, risk over benefits, what's most important. Breastfeeding. That first year of life, breastfeeding has a lot of benefits for the baby, but it's been shown to have benefits for the woman too, especially later on. So choosing to breastfeed is a modifiable risk factor. Alcohol consumption, smoking, obesity, high fats, all the other things that kill you in life can also lead to breast cancer, right?
So what's the link with the mother and children?
The hormones, the surges and the changes. Express some trifactor hormones. And a lot of the stuff is, all that vague, who really knows, family history. I think most current research is the evidence behind genetics, and then the hormones and the later in life of the children, and the surge in estrogen and the reducing comes back to increasing risk factors. This is a DEXA scan, which helps with bone density. So basically, it's an X-ray. This is the woman's pelvis and that hip. So what they're doing is they're looking. There's a baseline one done early on, before menopause, and then they continue to compare it to figure out what the risk factors are for osteoporosis. So as a woman ages, that area there in the neck of the femur will actually become more porous if they're developing osteoporosis, and your spores will change. So DEXA scans are part of routine screenings. They actually have portable ones that they'll take out to like health fairs and community screenings where they'll look at the heel, because the heel is also a very, very thick bone. It's painless. You don't have to do nothing but take off your sock and your shoe. You stick it in this little machine, and it gives out a report and indicates where you are, what that bone density scan looks like, and what your risks are later in life developing osteoporosis. So this is what it is. A radiologist, of course, will look at it and determine those numbers, and then it's kind of scaled and it helps with risk factors for osteoporosis. Now we get to talk about the boys. That's all about the girls. So Jeff would like to lead this section. Poor Jeff. It's probably been a real awkward semester for y'all. You know, these girly things, right? I'm not going to pick on you. I just say I'm sure it's weird. Okay, boys have to go to the doctor too, but the problem is, the other side of that is they don't go to the doctor like we do, right? Nowhere is it written in stone that a boy has to go once a year and put your feet up in stirrups or get your boobs smashed or anything else like it is for girls. And that's why boys sometimes have problems that they're not diagnosed initially, because men don't really like to go to the doctor, and they don't really have to go to the doctor. So health screenings for men, this is all covered in your med-surg book, and I pulled out the page numbers that you need to really look at. You will talk about testicular cancer. You will talk about prostate, and somewhere I think we talk about next week we'll talk about erectile dysfunction just a little. Okay, some more of that is later on. So these are that health promotion and screening that we're looking at. So testicular exams, we're going to watch a short video on that in just a minute. Your textbook says starting at the age of 12, boys should be doing this. The video has a little later in life. This is one of those things that recommendations constantly change. The DRE, digital rectal exam, that is where the provider, again, not the nurse, but the provider actually will go inside the rectum of a male and palpate that prostate for enlargement, tenderness, and pain. That's recommended on men routinely after the age of 50, so at least they have to go to the doctor again, right? And then colon cancer, men are a higher risk for that, so they recommend more routine screenings. From there, the questions are pretty much the same like a female. We don't really expect any discharge from down there, any pain, any abnormalities to the outward appearance. The good nurse will ask, the great nurse will look, if something's down there happening, we need to get it checked out, okay? And then our role usually is the chaperone in that environment. Because we're talking about reduction of risk, we're going to look quickly at testicular exam. So here are the words, and then we're going to look at the video. So boys should really begin to do them at the age of 12. They need to check one at a time, because it's a two-hand job. Maybe you giggle, right? One should be larger than the other. Sometimes that scares people, but one is a little larger, and typically it is the right. I don't know why, but don't tell you why. Typically it's the right that's a little bit larger. Whichever one is larger usually hangs a little lower, and incidentally the shaft of the penis will go in that direction. So most penises don't go straight up and down like a book shows them. They go off to one side, and usually the testicle on that side matches the one that's larger and lower. When they're doing this, they need to be feeling these little golf balls to make sure they don't feel lumpy. Testicles are kind of soft and non-lumpy, whereas a female breast can have some lumps in it and it'd be okay. Really, there shouldn't be any lumps on these things. The epididymis is along the back. It should not be tender. It kind of feels like a thin little rope back there, but it shouldn't really hurt. So next week we're going to talk about epididymitis, which is an indication of males of STDs. When you palpate back there and they say ouch, there's a problem. shouldn't really be able to, the prostate is only palpable once with a DRE, so that's really the only thing that you're feeling back there is the epididymis. And then notify the doctor of any pain and swelling. The best time to do this is after a shower. So when boys get into a shower, the heat, the testicles automatically drop away from the body because sperm can get killed in hot temperatures, hot environments. So the body's really smart and it drops those testicles down away from the body. That makes them easier to palpate. When young boys start this, they may not feel one on the other side. That's an indication one did not descend. Just like when they're little and we feel them when they're first born. That would be a reason to follow up because around 12 years old, they should both be down there where they belong. Young boys have a risk for testicular torsion. So they might be outside playing basketball, they're getting hot, right? They fall down away from their body and they get twisted up. That would be a problem. So if they are examining themselves, they don't need to examine themselves. That is a cut off of blood flow. They are in pain and they're crying and screaming, and that's a surgical emergency. So let's just take a quick peek at how to do this, okay? All right, Dave, come to me, because I won't break it again. And I just, this is the last slide. This is too much happening to hear technology right us today. Yes, we can get on that. I don't know why on the internet you can find all kinds of like things for girls, but on boys it's so hard to find. I guess the boys created the internet. Yeah, it's right there. Like when you click it, it shows up. See, have you got it? No, I don't have to get rid of all this. So okay.
Hi everyone, I'm Dr. Nancy Hood. Most people know me as a holistic nutritionist, but I'm also a certified yoga instructor. Fitness is a real.
I'm Dr. Nancy with prostate center. So how do you do a testicular self exam? Every man in the age of 18 and 50 years old should be regularly doing self-testicular exams. So how do we do this? Well, it's very simple. You place the testicle between the fingers in your hand and your thumb, and you can roll the testicle between the two. What you're feeling for is a soft consistency throughout the entire testicle. And it feels soft and malleable throughout the testicle. Really normal testicular exam. If you feel a hard knot or a rock inside, then that's an abdomen exam, and that should directly go to the doctor. Remember though, there's a structure on the back of the testicle called the epididymis. This actually carries the sperm out to the ejaculate, and it's a separate structure that hangs off the back, kind of like a backpack. So know that you're going to feel something separate off the back side of the testicle, and that's very normal. What's not normal would be that hard rock on the inside.
See, they just have it so much easier than we do, don't they? All right, so how do you study? How do you study? You understand these words. You be able to apply them. You're beyond knowledge. Okay, you're beyond that. So being able to apply them to a patient's setting. So A, this, all those terms that I gave you, understand. Prep U's great. You have a lot of complicated material on this test. So this is not the complicated material. Okay. Don't forget your developmental stuff. Make sure you're looking at that. This is just kind of, it is what it is. All right. Questions? All right. I will see you next week. Thank you.